Thank you, Physician Forum of India and Dr. Sushil Chauhan for giving me this opportunity to introduce Dr. Abhishek Mishra. He is an internationally trained and experienced senior orthopedics and joint replacement and arthroscopic surgeon, having more than 20 years of experience in this field. He has done his MBBS and post-graduation in orthopedics from Delhi University. He was a gold medalist in post-graduation program. He did his senior residency in a teaching hospital with high volume of patients in New Delhi. He went on to do several fellowships in countries like Germany, where he did a fellowship in primary and revision joint replacement with Dr. Thomas Seibel. He has done a course in navigation knee replacement in Austria and again an observership in primary and revision knee and hip replacement in USA. He has attended several arthroscopic workshops in Singapore and Hong Kong. He also did his MCH in orthopedics. He has worked as a senior consultant in orthopedics at Fortis Hospital, Delhi, where he had a privilege of having a navigation unit dedicated to himself. He specializes in primary and revision knee and hip replacement and minimally invasive spine surgery. So presently he is working in VNA hospital and is a visiting consultant at Apollo Spectra Hospital in New Delhi. He has the experience of doing more than 6,000 hip and knee replacement surgery. So he is known to all of us, and he is in fact a part of Physician Forum of India. So over to Dr. Abhishek.
Good evening, everyone. So, as Dr. Abhishek just said, it's always a pleasure to come back to this forum. This is like coming back to home, and home is always the best place. Home is where the heart is. So all the lovely people which I see here, my seniors, my friends, my colleagues, my contemporaries, and my esteemed seniors. Nothing can be more exciting and more pleasant to see you all and present in front of you. So two things very quickly. Like one thing is that very quickly I'm going to go through the slides so as not to keep you away from the dinner for very long. One thing is like why I chose this topic. I also was thinking orthopedic journey so far at VNA. How does it qualify as a CME? So basically during the course of these are primarily case studies. And during these case studies, we would be able to gather some knowledge about orthopedic management. And secondly, today in the morning at approximately 7, I had a WhatsApp message from Dr. Chauhan. And he sent me a song, Natu Natu. So I was actually, thinking why, I've heard so much about this song. Unfortunately, I didn't have time or inclination to actually watch the video. So he sent me the video, I actually saw the video and I was super impressed. And now just 1 hour ago, when Dr. Chauhan actually mentioned why he sent this song, I think this is the best song in the world. Thank you so much, Dr. Chauhan. Thank you, sir. So basically, very quickly, I'll go through the slides. Our hospital is just like in infancy. We have not even completed 1 year, and we have tried to do our best. Dr. Vineet here is he just presented a case. He's like one of the top urologists in Delhi, and probably I would go as far as to say in India, at least in North India. And we have done numerous cases. We have done the simplest of cases here in urology orthopedics, and we have done the toughest of cases. So I would just take you through this journey of orthopedic cases, what we have done here in VNA, at our hospital. So we actually care at VNA. So basically we will start with a very simple basic procedure like a bilateral knee replacement. This is a young guy, 52 years old, had severe difficulty walking and all. And fortunately, and he's a laborer, like he's not middle class or he works as a domestic help at somebody's home. It was actually his employers who paid for his surgery. And so this is a couple of days, third day after surgery, he was not able to walk properly, like to walk from one end of the corridor. When he came to the hospital to walk just the corridor of the hospital, it took him like 20 minutes. And this is just third or fourth day of surgery and going up and down the stairs. And he had never walked the stairs for the last 7, 8 years, 10 years. So this is a very simple, regular case. I would just encore, this is a 100-year-old lady, and I would Deepak.
100 years?
100 years, yes, 100 years old lady. So ours is a small setup. Ours is a small setup, and somehow we have a feeling, people have a feeling, doctors who refer the patient to us, they have a feeling that we won't be able to manage elderly patients or moribund patients or morbid patients at our place. So we did our hip fracture. So I'll just show you the, can we go back, sorry. So probably the audio works, I'm not sure. So just give me a moment. This is a 100-year-old lady. She had a hip fracture. She fell down. She came to us with all entire family. She lived somewhere in this place. ये कौन सी जगह है ये औरबिंदो मदर्स इंटरनेशनल स्कूल के पास there is a village. What sir? Achini. So she came from Achini and her entire, she had a clan of 100 people, all her family members. And they came because they were all counting on her to live because she was a very active lady. And we operated on her. We did, thankfully she did not have significant comorbidities except from a bit of hypertension and all. And fortunately, we were able to do it very nicely. And sorry. So, anyways, so we'll go ahead till the time volume comes. So, and we operated, and I was lucky, I was fortunate that we managed to do the surgery she's actually 100 years. And when she came for a stitch removal, this is the video, she came for a stitch removal, she was walking, she came walking to my chamber, of course with the help of a walker. And last visit, unfortunately, I don't have the video, she's still alive, she's kicking, and it has been almost 6, 7, 8 months since surgery. And now she's back to her old form. She's walking every day in her neighborhood. And she is still a father figure to all her neighborhood and her family. So now this lady, this was a challenge to me also. This lady came from Uzbekistan to get operated. She was approximately 160 kgs. And both her knees were super bad. So bad that she came on a wheelchair. She was not able to walk a few steps. Even to walk to washroom was a big effort for her. And somehow I had operated on one of her relatives and they had sent her to me. And actually, if you ask me, I was also jittery. Within my heart, I was scared to operate on her. And I'm assuring you that 90% of the surgeons, even the most brave heart of knee replacement or hip replacement surgeon, would defer or postpone or kind of not do her surgery. They would give some reason and try to defer her surgery, not to do her surgery. But somehow due to some moral obligations or due to some the trust or the faith with which she had come to me, I agreed to do her surgery. I would tell you that like her one thigh was equal to my 4.5, 5 thighs, and it was so big. The tourniquet, like the biggest tourniquet, could not was not able to circumferentially go through her thigh. And actually, ultimately, I had to do both her knees without tourniquet. Without tourniquet, there was a blood loss, but not so significant. And ultimately, I mean, we were able to, I mean, at some point of time, I thought I should abandon this surgery. Because it was like putting my hand in a tunnel. Like, a layer of fat was so deep that the bones were actually this much deep inside the skin. And I got so tired that at some point of time I thought that I'll just skip this, make some excuse that her blood pressure shot up or something, and I won't do this. But somehow I carried on, and finally I finished. And actually there was one complication. If you look carefully at these X-rays, you can see that one of the sides, right side, just because there was blood loss and there was no tourniquet, the visualization was not so good, not so great. And on the right side, you can see there's a rod. There's a rod jutting out. So actually, I managed. Unfortunately, I got something called notching on the right side, and because of notching, I had to change my plan, and I had to put a rod, intramedullary rod. I had to put you can see this intramedullary rod here, whereas it is not there on the left side. So this was a catastrophe. This was not a catastrophe. It could have been, but somehow she was able to do very well. And I'll just show you her videos like a couple of days after surgery. When she was walking in the corridor, or when she was walking in the hospital, she was occupying the whole corridor. She was so, her girth, her circumference was so big. And it was like 2-3 people walking in one go. Sorry, just give me, sorry for this glitch. Just give me 2 minutes. So this was her walking, like, and after 2-3 weeks, she was able to walk unsupported. And this was just after a week. I don't know whether this video works or not. Video chal raha hai? Can you just? So this was just first or second day after surgery. This one. So this was after a week, and the last one is after 2-3 weeks. We'll just skip through it like very quickly. We'll go through it. Anyways. And there is another lady. She came actually from Russia. She's a true blue Russian, royal blood. And I did she got an accident in Rishikesh while trekking and all. She got a fracture. Somehow she was referred to me. I did a rib replacement. I don't think our videos are working, so I'll just try to skip the floor. So anyway, this is just the second day after surgery. So let's go to the next slide. So now this guy, his name is Maqsood. He came from Uzbekistan, and he was like totally bedridden for last 4-5 years. Both his hips were bad, as you can see in the X-rays. Both his hips were bad. And honestly, let me tell you that I don't even know the reason. probably he has some congenital deformity, because these patients, they come with reports in their own language, and sometimes it's very difficult to translate them. And their doctors, their thinking is very different from what we think. Somehow they think of some strange diseases which we don't even know. But in any case, the crux of the matter is he was not able to walk. He was bedridden for last 3-4 years, completely bedridden. And this is the video after 2 days after surgery, when my physiotherapist is making him walk. So it was an amazing joy for him, touching the ground with his own feet after 3-4 years. And this is what he said. Volume, I'm not sure, but so anyways, let's go to the next surgery. Now this was a very interesting case, and this can be a learning also. This was a young seafarer. He was around 30 years old. He is working in merchant navy. His name was Vidyasagar. And he had got a fracture of shaft of humerus while on board. And he didn't only have a fracture of shaft of humerus, he also had a wrist drop, a retinal palsy. So he was somewhere in the he was working in the ship, he was somewhere in the ocean when he met with the accident. And next day he was operated. He was operated in Indonesia. He was operated somewhere in Indonesia. This is his X-rays of surgery in Indonesia. These X-rays are of the surgery in Indonesia, right? And this is the surgery which was revised. So I'll tell you the reason why it was revised. Basically, after fracture, after trauma, his fingers were moving. He didn't have any radial nerve injury, and after surgery, he developed a radial nerve injury. And in Indonesia, it happened, and he came to us. And unfortunately, the volume is not there, but I'll try to just kind of dump this for you. So here you can see this is the radial nerve in its entirety. So anyway, this is the radial nerve which you can see, and this is where it was injured. This area, you can see that the sheath, the epineurium and perineurium is not in continuity. There's a rent here. So basically, one of the screws, you could see probably in the previous X-ray that one of the screws was jutting out. You can see this screw here. You can see this screw here. These two screws, they were impinging on the nerve, and we changed the plate. We put a new plate with adequately sized screws, and we did something called neurolysis. And this patient, just 3-4 weeks after surgery, is fully recovered. He is able to use his fingers and wrist nicely, and he is a very happy and satisfied patient. Probably in the next talk, I will present his video. Did the patient send his video? No. Anyways, so in the next talk we'll present. So again, we are doing the spine also. This is the instrumentation of the spine. This was done at VNA hospital. This lady was in tremendous agony since last 4-5 years. Actually, this is one of Dr. Vinny's patient. One of Dr. Vinny's patient's mother. And we operated on her, and she's again a satisfied patient. Canal stenosis operated at one level and doing very well. This is the X-ray of kyphoplasty, which is a procedure which is done for compression fractures of the vertebra. And this is done at 2 levels. Now this was a very interesting case. This was a case of habitual dislocation of patella. And this is a 19-year-old guy. Again, he came from Turkmenistan. And you can see the patella moving out. You can see the patella has gone laterally. So every time the patient bent the knee, the patella used to kind of dislocate. And ideally, such cases should be operated during childhood, like 5, 6, 7, or adolescence, before skeletal maturity. But this patient came very late to us, and I was again little apprehensive about his surgery. But fortunately, we were able to manage. Like this is the procedure during surgery. You can see we have done like something called lateral release and medial plication, and you can see that the patella is stable throughout the range of motion. It is not going out. And we also needed to do something called tibial tubercle osteotomy. So which you can see in the X-ray previously. This is what we did, tibial tubercle osteotomy. And you can see that during the entire range of motion, the patella is like stable, it's not moving, it's not dislocating. So next case, again, this is Dr. Vineet has been very kind. He refers all his patients to me, whether the patient needs orthopedic intervention or not. Unfortunately, I can't do the same to my patients. So again, this was Dr. Vineet's patient. He had operated on him. He was very satisfied by Dr. Vineet's job. And there's an interesting story. This is an Indian guy, Prem Prakash Thapar. He's around 87, 88 years old, but he's a Japanese citizen, and he has a big business there. So Dr. Vineet somehow helped him by helping his organs, and he wanted his knee to work also. He was operated like many years ago, and he had undergone a partial knee, like hemi. This is like hemi or unicondylar knee or partial knee replacement, and rest of his knee had become bad over a period of time. Usually partial knee, it lasts for 10, 15, 20 years, not more. So he had undergone this partial knee replacement, and I don't know why the doctors in Japan, they told him that you are too old to undergo like a revision surgery, or your situation is critical and this surgery is the magnitude of surgery is very high. Probably you won't be able to bear and all. And we did this revision. This is the revision. We did his full knee replacement, and this is the mail which he sent to the hospital after the surgery. He sent the mail to Dr. Vineet on the hospital's mail, and he actually wrote that he showed this X-ray to the doctors, to the orthopedicians in Japan, and they were pretty impressed by the work we are doing here. So this happens every time. Like I'll tell you, I've trained in like at least 6, 7, 8 countries, and the nature, the quality of work we do here. I'm not talking about myself. I'm talking about the orthopedic surgeons in general. The quality and quantity of work we are doing here is, if not much better, it's not less than anywhere else in the world. We're as good as US or UK. Probably the reason is the patients come to us at a very late stage, and we get to see mostly complicated or advanced disease, and we are lucky enough to operate on them. Whereas in Western countries, the acceptance to surgery is very high, and people get operated at a very early stage. So last few cases again, like this is the same guy, and this is his video. Now this lady had operated just yesterday. Probably you can see in the X-ray. This is the X-ray which was done on like, I don't know, 13th or 14th, and this is the post-op X-ray. I operated on yesterday afternoon, yesterday in the evening actually. And this video I'll just show you. Actually, I wanted to play this video because there was a message here, but somehow I'm unfortunate it's not working. But in any case, I'll show you this. Now, you can see that we fix phalangeal fractures and we fix spine, and knee and hip comes in between. So what a message was, we are doing everything. Don't think that we are small and we are ineffective. We are as big as any big giant. Thank you very much. Thanks.
What a nice talk. So, robotics versus mix versus conventional. What do you choose, sir?
I knew this question would come up. Let me compliment you, sir, for the amazing turban and waist coat you are wearing. I love this color. I love this green color. This is one of my favorite colors, actually. And this is not, I'm not, this is genuinely one of my favorite colors. So about robotics, I'll tell you. Actually, somewhere in my laptop I have one present, but somehow some of my very trusted people have deserted me and my laptop's volume is not working. There's a guy, he's called Dr. Vikram Shah. He's, if you Google, he is one of the most renowned knee replacement surgeons in India, probably the world. And probably he does the maximum. Volume come karega? Nahi karega to koi point nahi. So basically, this Dr. Vikram Shah is like, in the entire world, he is the one who does maximum number of knee replacements. He has a hospital called Shelby Hospital, it's in Ahmedabad. And now this Shelby Hospital is spreading across India. And
बंद कर दो उसे, बंद कर दो.
And I'll tell you one more thing, like, sorry, I'm taking this question tangentially. Shelby Hospital, I'm affiliated with Shelby Hospital in Wadhwa and Lucknow. I go there to operate from Shelby Hospital's room. Unfortunately, they don't have any hospital. They had approached our hospital, but right now we are not interested in tying up with them because of some reasons. So this guy, Dr. Vikram Shah, he owns a private jet, and he is one of the few doctors in India who actually owns a aeroplane. So this is just the background. What I'm trying to do is, I'm trying to answer your question, sir. This question is asked again and again. And the bottom line, I will tell you, Dr. Shah always answers, that's robotics, to be very honest, is just a marketing gimmick. I'll tell you one more thing, what examples what he gives. Like if you're in an aeroplane, now these are not my quotations. You can go on to YouTube and just type Dr. Vikram Shah is speaking on robotic knee joint replacement. Robotics are actually for inaccessible organs like brain, where getting to a specific area is very difficult and risky. Knee is the most superficial joint. You can go very easily, no need for robotics. But then again, there are so many players, you have to show yourself high somewhere. I also use this gimmick called navigation when I was in Fortis. I had this machine for entire 2 years. But let me be very honest, I never used this, not even in one patient. It was just to show the patients that there is a machine lying here. If you ask any orthopedic surgeon who propagates that he is doing robotic joint replacement, and if you ask him that show me one operation in which you are doing robotic, then he will give you a particular time. You can't just walk into his OT and see this robotic joint replacement.
Thank you, sir.
Because routinely he is not doing it. I'll tell you the reason, sir, but it will be very long. It will be a very long list. But I just told you the crux.
Sir, just to wind up, I want to congratulate you for Natu. And I think Natu is a litmus test for the orthopedics, say osteoarthritis and all that. Those who have osteoarthritis, they can't do it. And sir, what about habitual dislocation case which you told about patella? Was patellectomy also a choice for them?
Absolutely not, sir.
Okay. And about, you said that Vineet sends all patients to him.
Most of, not all.
Because they all have joints.
No, sir, I'll tell you.
But you can't send them because they don't have prostates.
I'll tell you something that you see. I don't know, somehow it's no, sir. All have knees also, sir. All have knees also. But let me tell you something, sir. I'll tell you, sir, there is a difference in thinking between Caucasian, between Indians and other population. You see, if most of these people, like who come from Africa or Europe or Russia, whatever, if his knee is not working, if his other organ is not working, he is more concerned about his other organ. And we go to Dr. Vineet first. He will not come to me. Whereas in India, they come to me first for the knee. They want to be mobile. But most of the people from other continents and all, they are more concerned about their other organ functioning than knee. Which is very surprising. Which actually I am shocked by this.
Yes, Dr. I think friends